Welcome to 4Sight Friday Roundup, 4Sight Health's podcast series for healthcare revolutionaries. Outcomes matter, customers count, and value rules. Hello again, everyone. This is Dave Burda, news editor at 4Sight Health. It is Friday, March 19th. As I'm sure you know, this is Patient Safety Awareness Week. There's just one day left, and that's tomorrow, so you better start checking those central lines for signs of infections. So on today's episode of 4Sight Friday Roundup, we're going to talk about a few patient safety-related things that happened this past week. We're going to talk about the New York Times piece on nursing home star ratings that don't necessarily correlate to safe and effective care for residents. And we're going to talk about the annual list of the top 10 patient safety concerns from the ECRI Institute, which is like Consumer Reports but for healthcare. To hopefully make care a little safer for all of us are Dave Johnson, founder and CEO of 4Sight Health, and Julie Murchinson, partner at Transformation Capital. Hi, Dave. Hi, Julie. How are you guys doing this morning? Dave?
I'm doing great. Feels like spring is in the air.
Julie, how about you?
Good. California just opened up the next tier of vaccinations, so I'm waiting with my hand on the mouse to sign up for the next time we open up. It's going to be my turn.
Wonderful. Good luck.
Thanks.
Now, before we dig into the New York Times coverage and the ECRI report, let me ask you guys about your patient safety experiences. Dave, have you ever caught and corrected a potential medical mistake for yourself or someone else?
I'm always on the lookout, Dave, but haven't caught one at this point. I will tell you one kind of interesting story. I was in for surgery quite a few years ago, and it was right after a hospital in Illinois had amputated the wrong leg for somebody. Pretty bad mistake. The guy in front of me going in for surgery had a black magic marker, and he was writing on his two legs. One was right leg and the other was wrong leg. So I thought that was very good personal preparation for a mistake.
Right. That's patient engagement right there, huh? All right, Julie, how about you? Did you ever say, hey, wait a minute, to a doctor or nurse for yourself or someone else?
I absolutely did. I was on bed rest with my first son, and the nurses used to come in at all hours of the night, which I found extraordinarily annoying. But one night, about 3 nights in, the nurse came in to take my blood at like 2 o'clock in the morning, and the doctor had just told me that was going to stop happening the day before. So I said to the nurse, listen, I just had this conversation with the doctor. You don't need to take it again. We're sort of in steady state now. And it was a bit of a battle with her, but she didn't take it, and the whole thing got resolved the next day. So I don't know if it was an error as much as avoiding unnecessary care.
Good for you. Now, we did have an ENT who wanted to take my youngest son's tonsils and adenoids out, in addition to putting tubes in his ears, because in the surgeon's words, it would be more convenient for me if we did this all at once.
Why not the appendix too?
Yeah, just take it all out, right? Yeah. So we switched ENTs. We had the tubes put in, and Jeff still has all his original parts and no unnecessary surgeries. All right, let's celebrate Patient Safety Awareness Week before it's too late. Dave, tell us what the New York Times reported this week about star ratings for nursing homes and the care provided by nursing homes. What are the big takeaways, especially for consumers?
The Times has undertaken a massive investigative report on the nursing home industry with a particular focus on its star rating system. I encourage everyone to read it, but it's not for the faint of the heart. Much of it reads like a Dickens novel: maggots and wounds, sexual abuse, neglected residents, fraudulent reporting, heartbreaking individual stories. Before I summarize the report's findings, let me briefly outline the mechanics of the government star rating process for nursing homes, which began in 2008. It has 3 components: state inspections, many of these surprise inspections; nursing time with residents, that's self-reported; and then a quality of care score, which is a composite of 15 metrics relating to measures such as wound care, falls, and over-medication. There are 15,000 nursing homes in the United States. 70% are for-profit. A lot of them are mom and pop operations. Almost a quarter have 5-star quality ratings. So here are the New York Times key findings. Number 1, the star rating system is catastrophically broken. Number 2, much of the self-reported data to CMS from the nursing homes themselves is wrong and almost always biases in favor of the reporting institution. That tells us it's not random. Nursing homes inflate their staffing ratios, underreport the number of residents on antipsychotic drugs. Often accidents and health problems go unreported. 4, CMS rarely audits nursing home data, even though it is so often wrong. And finally, a majority of nursing homes seems to know in advance when quote unquote surprise inspections are coming, and they staff up for them. One of the things I particularly liked about the Times reporting was their focus on the 5-star facilities, roughly a quarter of those, as I said earlier, a quarter of all nursing homes in the United States. And here the news is not good at all. 5-star facilities were as likely to fail in-person state inspections as pass them. 70% of 5-star facilities receive citations during the review period for problems with infection control and or abuse of residents. Star ratings correlate with profits, not with quality outcomes. So clearly the facilities are managing to the star rating, not to giving the best quality care. 5-star facilities are the most profitable. It's clearly easy to game the rating system, particularly for the staffing ratios. Several examples of reporting vacation time and staffing ratios or administrators in staffing ratios. And finally, COVID deaths occurred at the same rate in 5-star rated nursing homes as in lower rated nursing homes. So despite that higher quality rating, weren't any more prepared for COVID. And of course, COVID has devastated nursing home populations. A quarter of all COVID deaths have occurred in nursing homes. And believe it or not, Dave, 1 in 10 nursing home residents have died from COVID in the last year, 1 in 10. You asked the question about impact on consumers. The real tragedy is that so many Americans, including us, rely on star ratings to make decisions regarding their loved ones. Just an absolute tragedy.
Wow. Thanks, Dave. Julie, what's your take on what the Times reported? And to pick up on Dave's last comment, what does it mean for the future of CMS Star ratings for others like hospitals and health plans?
Yeah, well, first of all, I mean, it's just sickening, and there's just no two ways about what they found. It's quite an investigation. I'm a big believer in rating systems, honestly, for quality in particular, and I think they're here to stay. Without them, just imagine the scope of the issues we'd see in so many areas. So, of course, the problem is that many of these are manual systems, and they can only screen for so much. They're obviously way too easy to fudge. And the corruption in the system and the bribery that Dave alluded to in the oversight function, we just have a lot of systemic problems. Yeah, there are a few issues I look at. First, most of these measures are still very process-oriented measures, and we're not anywhere close to like true outcomes measures. And there's a lot of reasons for that. But we know we need to get closer and closer to what outcomes measures look like. So that's really about patient health and patient satisfaction. And in this case, a lot of family satisfaction as well. And while we're working towards these kinds of outcomes, there are certainly ways we can be thinking about the digital nature of some of what's happening as well. So a couple ideas here. First, we could start including more revealing process measures. So things like, in addition to just staffing hours that Dave talked about, looking at nursing turnover and tenure and more kind of indicative process measures. Both the OIG and HHS have recommended things like this, so this is not necessarily a new idea. Second, automation. We have a lot of automation happening in healthcare in general. The nursing home setting is not necessarily at the front of the line of being the most digitally oriented, but as more source systems come in, certainly payroll data systems are more automated. Looking at how you can actually integrate measures with actual payroll or clinical systems. A lot of the quality measures themselves are becoming digitally native. So this can go a long way to ensure more end-to-end truth is being told, just from automatic checks and balances in more automated systems like that. And last, I think, CMS could develop a series of more qualitative metrics based on consumer and, again, family input. So really looking at what's important to them. And industry leaders and regulators know that they have to work on this. Certainly now, it's a great wake-up call. And what matters most is, what's best for the residents and the patients. So I think we're going to see some change here, honestly.
Great. Yeah, lots of good ideas there, Julie. Thank you. Dave, anything to add to Julie's comments?
Well, I generally like to have a glasses half full perspective on these issues as well as a negative one. It's hard with nursing homes. But on the half full side, we did see the government of California's Justice Department, which is still run by Javier Becerra, bring suit against Brookdale, the largest owner of nursing homes in the country, for fraudulent reporting. So perhaps that indicates stepped up regulatory coverage or focus. And also just picking up on Julie's point, I really like star ratings too. We're supposed to make it easier for consumers to pick, but the ratings have to correlate back to actual outcomes so they mean something. So I do believe that's an opportunity for innovative companies in the rating sector, but also, as Julie outlined, I thought in some exquisite detail, how we can use technology to automate reporting and also as fail-safe mechanisms to prevent things like falls in nursing homes and so on. So not a happy story at all, Dave, but there is a little bit of light coming through the door.
Yeah, no, I've seen a lot of 4-star movies I didn't like, so I hear what you're talking about. Now, let's talk about the other patient safety elephant in the room this week, and that's ECRI's new list of the biggest patient safety risks right now in the industry. Julie, which of ECRI's top 10 caught your eye, and what's the patient safety lessons for providers moving forward?
Well, no surprise, the 2021 list was dominated by issues that were exposed by the pandemic. It feels like a very timely list. Numbers 2 and 3 were explicitly noting pandemic preparedness among aging and in general. And others like number 4, supply chain interruption, and number 5, drug shortages, seem to be very closely tied to what we experienced during the pandemic. I loved number 6, which cited telehealth workflow challenges. I'm not sure we've seen telehealth on lists like this before and anyone was really paying attention. So it seems to me that the pandemic has warmed us up and warmed my heart. That was a good one. Of course, number 1 was by far the most interesting and probably the first time it's ever been on this list, racial and ethnic disparities. We all know the pandemic has shone a bright light on this enormous tragedy. And what's, of course, upsetting is that this has been in the data for a long time. So it's really just the sheer numbers that were really difficult to ignore. And when you look at Ochsner in Louisiana, who saw that 77% of the COVID deaths in their hospitals were Black, yet only 30% of Ochsner's patients are Black, it's hard to ignore these numbers. And it's funny, Dave, I used to work with a woman named Kim Weiss who works at Becerra, and she and I were talking last week about patient safety in anticipation of this week. So this is a very timely topic for me. And she's working with the famous consumer experience expert, Bridget Duffy, and Becerra's CEO, with a number of health system leaders. So we're getting at that place where leaders are starting to really look at what does patient safety mean with them. And some pretty interesting stuff going on there. They are really looking at how patient safety is tied to staff safety. And if you want to care for patients, you have to really protect caregivers. So it's a totally kind of different lens on it. But what came out of their work is pretty aligned. The 3 areas that they thought deserved the most attention were, first, safeguarding the kind of psychological and emotional safety of caregivers, staff, nurses, environmental services, everybody, soup to nuts. Second was promoting health justice and actually declaring that equity and anti-racism are really core components of safety and recognizing that this is not necessarily something that's well done in health systems today. And the third is ensuring, of course, physical safety. And it's their belief that if they can really carve out a space to start to make this kind of change among caregivers, that the safety of patients will rise in really material ways. So I just wanted to share that thinking because I was struck by it, especially when I read this ECRI list, thinking to myself, we don't even talk about these connections, and it's important to think about.
No, that's great. Interesting approach to connecting the caregiver to the patient. That's great. Thanks, Julie. Dave, which of ECRI's top 10 did you agree with or disagree with, and perhaps pose a safety hazard for patients well beyond 2021?
Well, first off, ECRI ought to go into the nursing home business and start doing ratings there. I mean, it's a terrific report. It's independent. And the fact we rely on the government to do our quality and safety ratings is really pretty unusual. We don't do it in any other industry. I don't look up for government ratings, when I'm picking a restaurant or buying a car. So good for them and great report. Like with Julie, number one really resonated with me. I did a deep dive on Martin Luther King Jr. Hospital in South LA related to COVID. Very small hospital, 130 beds. And despite heroic efforts on the staff, 90% of the patients put on ventilators died. That compares with about 50% nationally. And they couldn't transfer their sickest patients to the big centers, UCLA, Cedars, and so on, because they wouldn't take them, most of them on Medicaid. Draw your own conclusions there. So here you had this tiny community hospital treating as many or more COVID patients as these big centers. So racial disparities. What I'd say is I think this report was heavily influenced by the pandemic because the pandemic has really revealed some structural flaws in the system. I went back and looked at the 2020 list just to see how much difference there was, and there was quite a bit of difference. But there, the top three were diagnostic errors, maternal health, and then early recognition of behavioral health needs, so mental health. So 1, 2, and 3, diagnostic errors, mental health, and 3, early recognition of behavioral health needs, mental health needs. And number 10 was fragmentation in the system. And I actually came to the conclusion that if we dealt with 10, almost all these other things would take care of themselves. But when you put together what's happened during COVID, the racial disparities, our conversation on nursing homes, and the fact that in maternal care, we still have disproportionately high numbers of women, particularly from low-income groups and ethnic groups. We have some fundamental equity issues as it relates to healthcare. And I'm going to end my comments by a quote from Hubert Humphrey that said, "The ultimate moral test of any government is the way it treats 3 groups of citizens. First, those in the dawn of life, our children. Second, those in the shadows of life, our needy, our sick, our handicapped. Third, those in the twilight of life, our elderly." And I got to say, despite all the money we're spending on healthcare, I don't think we come even close to passing that Hubert Humphrey standard.
Thanks, Dave. Julie, anything to add to Dave's comments?
Well, it's hard to follow that quote, but I'll just say that Dave and I mind melded on this because I went back to the 2020 list and highlighted maternal health, early recognition of behavioral health needs, and fragmentation across care settings.
Great minds, Julie. Great minds.
Exactly. What made me laugh about these lists is that they put things on lists that are so important, but what's happening in healthcare, as we all know, is that these things are critical for years, if not decades. So the list could be 100, I'm sure. We have a lot of work to do. And if you just get back to some of the comments I made earlier about caregiver safety and its relationship to patient safety, behavioral health needs, I think, are very central to some of that thinking. So we know we have a tsunami coming.
Right. And another year doesn't mean they all went away, right?
Exactly right.
Good point. Now let's talk about next week. Julie, what should we be on the lookout for next week in terms of big healthcare news?
Well, this week we had a huge healthcare deal with Doctor on Demand and their merger with Grand Rounds. So I'm not sure we have another one of those in the back pocket. I'm going to turn back to some that I've been reading about the topic we've been talking about today, which is nurses. And I don't know if you've been following some of the news around nurses, but we have seen more nurses crumble, leave entirely. And we've actually seen a lot of nurses checking themselves in or 5150ing into acute care centers on the behavioral health side. I just think we're starting to really see the after effects of those who have been at the front lines and central to all the pandemic. And I'm concerned we're going to see a lot more of that.
Right. Wow. Dave, what's in your healthcare news tickler file for next week?
Well, first off, really interesting merger with Doctor on Demand and Grand Rounds. Go Owen Tripp. It's another example of these digital companies like Livongo Teladoc, really, I think, creating a new paradigm. So, Julie, great job flagging that one. What I'd hope we'd be talking about next week is racial violence and gun violence, because those are healthcare issues given the recent shooting in Atlanta. But I fear by next Friday we'll already have moved on like we always do. And if I have to predict, I think we're going to be talking about immigration, health safety, and mental health issues, as that seems to become a very pressing need, but also a very pressing political talking point.
Got it. Thanks, Dave. Thank you, Julie. That is all the time we have for today. Great discussion as always. And clearly, let's all be careful out there. If you'd like to learn more about the topics we discussed, please visit our website at 4sighthealth.com. You also can find this podcast and all our podcasts on the Healthcare Now radio network, iTunes, Spotify, and other streaming services. Thanks for listening. I'm Dave Burda for 4Sight Health.